John Whitman with Babson College. As somebody who does research on cooperatives, I wonder if any of you would care to offer what you think are the most important needs for future research on cooperatives in ways that could help you.
Well, I'll respond to that. We have, is that okay?
Go. Yeah, go.
For us, it depends on what the project is. But right now, we are involved with a group actually out of Seattle and wanting to grow the cooperative movement again, I guess. Back in the 70s, it was quite popular, and throughout the 80s, as packing houses failed and people got a bad taste in their mouth from cooperatives. And by the way, I don't think that that's because cooperatives are a bad business model. Businesses come and go every day. What's hard, though, is that these cooperatives are locally based, and that institutional knowledge stays in that community for a long time when those businesses go under. But so cooperatives were making a resurgence in 2000, and they certainly are making a resurgence now in the economic recession that we're all experiencing. So this group that we're working with in Seattle, we're launching a survey right now. And that survey, there's two primary objectives that we're looking at. One is that we want to better connect the community, so we're going to create a survey for the Cascadia region, which in our case that is going to represent Washington, Oregon, and Idaho. And the other piece that we're looking at is what is the appetite of the cooperative community to create a cooperative development fund? And I don't think I'm entirely answering your question, but there's all kinds of information out there to research. It just depends on what the group is trying to achieve.
I'm going to stick my mouth in here, which I try not to do, but I thought I heard some really great requests for information from you, Joy, when you said you need to prove that cooperative outcomes are better, that cooperatives have something to offer above and beyond. And I think that in terms of certification of workers, that is, more workers are certified, an actual demonstration on a wider basis than one co-op, that turnover rates are lower, client satisfaction, all those things within the cooperative home care setting would be enormously beneficial. No, you do, because it doesn't come to it honestly doesn't come through.
I'm honestly on the mic now. I think one of the existing data sets that exist for Medicaid insurance companies is the HEDIS data, the health effectiveness data information set, and it exists, and it is created to measure effectiveness, and I believe that it would be a great step for home care to start to do in home care what a lot of the hospitals and primary care clinics are doing with respect to hospital discharge and somebody being readmitted within so many days. And certainly from a nurse practitioner perspective, one of the things that has finally come through is looking at nurse practitioners' outcomes compared to primary care physicians with respect to some of these chronic disease outcome measures in diabetes, hemoglobin A1C, and hypertension, having blood pressures sustained and maintained. And I think that there are these other examples of how some of the data sets are existing, and now what we want to do is move it from the clinical setting, like we did with nurse practitioners vis-a-vis physicians, and now start looking in home care at cooperative-based home care givers compared to perhaps agencies, and look at some of those outcome measures that are being measured with respect to everything.
I just want to add, I mean, I think it's very easy to talk about this. I mean, I would not begin to even think about outcomes because you haven't even developed a really sustainable model with the exception of a couple in the country. And I would be really loath to have you do some treatment control comparisons of what a co-op model produces relative to anything else. To me, it seems as though you need to begin to better even understand what would a co-op model look like that was truly value added relative to something else. And maybe, as you said, think about some kind of a demonstration activity that was very controlled. But I don't think this is in any place. I mean, we don't even have measures of home care outcomes, quite honestly. We have OASIS for the Medicare home health, but there's really nothing for home care, non-medical home care. So it does seem to me that you need to be doing a little bit more around identifying what this model is that would distinguish you from an agency, a for-profit agency, other entities in the community, because that is maybe what would market you better. But I wouldn't go to outcomes yet, because I don't think you'd be able to demonstrate outcomes relative to an agency model. There have been some studies done of consumer direction compared with agency models. Mathematica has done some studies, and UCLA has done some studies looking at consumer direction versus agency directed, and have found that there's no jeopardy in quality, and that consumer satisfaction is better in a consumer-directed model than it is in an agency-directed model. And that may have some relevance to the co-op model, because the co-op is closer to a consumer-directed model than it is to an agency-directed model. But if I were you, I would pay attention to what are the distinguishing elements of the home care co-op that make it viable and valuable in a community that's going to distinguish it from something else.
I have a question about the multi-stakeholder type of cooperative, and really for anybody on the panel. It's true that we need a lot more research. We always do. I work for the Senate Special Committee on Aging, by the way. And yet we're at a point in our development of our healthcare system where we're really trying to figure out what concepts are, and then put meat on those bones in regulation and in guidance, and basically creating things that hardly exist, like accountable care organizations. So when I think about the multi-stakeholder cooperative, which I've just heard about today for the first time, I'm wondering, can it include a number of different kinds of healthcare providers who could, provide the full range of health and long-term care services, sort of like the PACE model that was referred to, the rural PACE program in South Dakota, that would serve a group of people who came with an income stream over a period of time, and then essentially meet the measures that are required, let's say, of the PACE program or whatever the other, nearest model is? Or is it too early for the cooperative model to broach that?
You want to give a first approximation of that, Margaret?
I'm not that familiar with the PACE model, so I have difficulty expressing that. But what I have seen of multi-stakeholder cooperatives, and it is a relatively new model here, it's very flexible, but you need to include people as members of the cooperative that have significant skin in the game and that are going to be in it for the long term, rather than just on a little advisory board type of thing, or just helping out in the first, creation stage. And then people, if they're going to be involved, they need to be involved for the long term, and structure it that way.
Once again, I'm sorry, but I'm going to put my mouth here. This is my business, structuring organizations, so legally. The co-op model is flexible enough to do it, and the multi-stakeholder model is flexible enough to do it. The question is, do you have the right groups, and are they willing to negotiate around the right things? Okay? It's perfectly theoretically appropriate to imagine a group of people whose measure of success is patient outcome, negotiating the best possible coordination of that patient outcome within a cooperative model. The problem is always where the rubber meets the road. Who gets what, and how do you determine? When you have different people adding different elements of value into a setting, how do you price that, right? This is what I think of as a value-added cooperative, but you have to be able to negotiate those prices at the beginning. Well, that's where the value added is where the savings go. To the extent that you're adding value to the cooperative, you get that portion of the savings, but you have to negotiate that piece out. And it's the hard part. And it's the same hard part that you find if they're not a co-op. This is a hard thing to do.
And I would certainly want to stress that the workers need to be a primary part of this, because, I mean, these are the frontline workers. And you can structure it in such a way that you could have certain representation on the board, and that perhaps if there are patronage refunds, that the caregivers would get the majority of that. I mean, you could do some interesting things with structuring, but I certainly would not want to lose sight of the caregivers as a vital part of this, and make sure that their voices are heard, and that they are part of the patronage refunds of the sharing of the profits of it.
And I can give one example. Western Healthcare Alliance is located in Grand Junction, Colorado. The director there, what she does is each year when it's time to do their dues renewal, but it's a hospital network, so all of the members are hospital, is she has a whole menu of benefits that the members can participate in over the year, and they track it. And so at the end of the year when she does the due statements, and she'll say, by the way, this year you saved this much money, and she'll actually put a figure on it so that they can see. The other thing that she does in some of the programs that they offer are actually the members do receive money back at the end of the year, so that they actually get a payment back. And I think the last time she mentioned it to me, I want to say $500,000 maybe was the amount of money that some of the hospitals actually were able to get back at the end of the year based on using the services that had been developed based on the needs that they had identified.
There have been for many, many, many years, and our chair, CDF's chair, Gap Kovac, will tell you, agricultural cooperatives with different patronage pools. So it's not an unusual thought that you would have a variety of different inputs with a variety of different patronage rebates. But again, it's the negotiation, because you have a single outcome, that is the issue.
Well, it seems to me after such a great day today, the next question is, and I know that this is probably Liz's, the next steps, but what Dr. Stone talked about with advocacy, it sort of seems to me that there needs to be almost like a vision or a blueprint of how to take the few really good examples that are here and even learn from the lessons where things that failed, because I think we learn often more from things that failed than the successful ones, which were just that they had great people that had been advocating for things in their community where they found a need.